Hello, it's working. Is it working? Hello. Okay. Yeah. All right. So for today, we're going over Chapter 4, Classification and Assessment of Abnormal Behavior. We're basically talking about diagnoses and how we come to the conclusion of a diagnosis. So a diagnosis is simply the identification or recognition of a disorder, looking at the characteristics that enable us to make a diagnosis. So we're looking at the things that people have in common with other people who would have the same diagnosis. You're looking for depressive symptoms for someone to get diagnosed with depression. You're looking for anxiety symptoms for someone who would get diagnosed with an anxiety disorder. It's using what information we have available to us about previous people who have a disorder, such as the information you would have in a textbook like what you've got in the DSM, the Diagnostic and Statistical Manual of the American Psychiatric Association. So these are things that we use to determine whether or not someone has a diagnosis. It's also really important to remember that a diagnosis is simply a label. And labels can be problematic, but we have labels in order to get paid for the work that we do, for insurance companies to be willing to reimburse people for the work, for the services to be covered by people's insurance, so they don't have to pay for the services that they're already covered by insurance for those services. So things like that are a big part of why we have the diagnoses. Their value as far as the good that can come from it. I mean, sometimes having a name for a problem can be helpful, but sometimes it can also be hurtful. So I'm not going to sit here and go, well, we really need to have a diagnosis. What people really need is some help with the problems that they're having. Being able to slap a name on it can actually, cause more problems than good in some folks. So again, it's kind of a mixed bag. Why do we need a system to classify abnormal behavior? Well, all the stuff I just said, so we can get paid, so people cannot have to pay for services, to be able to have people be able to agree from one clinician to another as to what is actually a diagnosis for a certain set of symptoms. So the two main diagnostic systems that are used, ICD-10 is the International Classification of Diseases, which is used in a lot of the world. And then we have the DSM-5, which again is a product of the American Psychiatric Association. So it is primarily used by English-speaking countries and Western countries, of course. And there are problems with the DSM. There are problems with ICD. It just is a way that we can have codes to input into billing systems and things like that. So again, having a name for something is all well and good, but it's far more important to get people the help that they need. The name is not nearly as important. One of the things that's important about having a diagnosis is it can help other clinicians quickly understand what they're dealing with. If I have a client that comes to me and says that, they've been in therapy before and it was for their MDD or their major depressive disorder, that automatically gives me a pretty good idea of what kind of symptoms the person is experiencing, what kind of issues that they're going to be dealing with. And it'll tell me, kind of how to start uh, working with them to, reduce their symptoms. So those kinds of things are really important. Reliability is just a consistency of measure. So when you're talking about diagnostic decisions, you really want people to have reliability and inter-rater reliability, meaning that if you present with symptoms of depression to a therapist here in Arkansas, and then you move to Arizona, the therapist in Arizona should hopefully also give you the same diagnosis since you're presenting with the same symptoms. Inter-rater just means from one person to another. Reliability is really important. We want people to be able to be consistent with their diagnostic criteria. That's part of why we have the ICD and the DSM-5, to be able to have that consistency. So we're kind of all on the same page, working from the same set of tools and using, the most beneficial techniques and in a lot of cases medication for these individuals to get better. Validity just means that it's doing what it's supposed to do, the meaning. Validity means that it's measuring what it's supposed to measure, or it is describing what it's supposed to be describing. So if you have, a valid diagnosis, it means that it actually matches the symptomology that is presented. So that's a relatively straightforward. Comorbidity, I mentioned before, it's just the existence of more than one diagnosis in an individual person, which is quite common amongst people who have psychological disorders. So again, that's just something else for us to be looking for when we're doing intake interviews. So an interview, biopsychosocial assessment, they're called intake interviews or intakes. Generally in the business, we just call it an intake. An intake interview is generally scheduled for a couple of hours. And oh boy, you take every bit of it usually, if not more. We can get paid for up to 2 hours. If it goes over that, you're on your own. You're not getting paid. So it's definitely good to get it down to a science where you can get it done in 2 hours. But it can be tricky. I have had cases where I did an intake that took, 2 hours and 15 minutes because there was just so much to unload, so much to unpack with some individuals. With the kids that I worked with, sometimes I'd be dealing with multiple people. I'd be dealing with the foster parents. I'd be dealing with their DHS worker, maybe a CASA worker. That's court-appointed special advocate that can be assigned to a kid in the foster care through the court system. There are, all kinds of potential, people that might be involved in an intake with a child, especially, in this circumstances like foster care. So, in some of those cases, it would take me longer, but, it's part of the gig. We got paid. I got paid well, so it never really bothered me too much if it went over by 10, 15 minutes. Big whoop. I'm already getting paid quite well, so not a big issue. What I do have here, so this is an old intake packet from when I worked for Methodist Family Health, and the main thing I just kind of want to be able to show you guys. This is 12 pages long. There's a lot of stuff in here. One of the things that I always kind of marveled at is like, hi, I just met you. I'm going to go get all up in your business and ask you all kinds of super duper personal questions, and you're kind of expected to answer them. So obviously it's real important for people to be comfortable with you very quickly. So again, when I talked about using some of those client-centered therapy issues, the unconditional positive regard is when you can start showing people right away. The genuineness you can start showing right away. The empathy you can start showing right away. And fortunately, I did not typically have much problem getting people to be willing to talk to me. I try just in general to not be a judgmental person, but especially when I had my counseling hat on, I would try very, very hard to just be like, okay, so yeah, all right. There were times when it was inside, I was going, holy crap, but you don't let it show. Got to keep that poker face on to some extent. So with this, one of the things at the top, who's actually giving you the information? Is the client? Is it the client's parent? Is it their foster parent? Is it the DHS worker? Again, all of that information. Chief complaint or presenting problem. So why are you here? Why are you seeking treatment? There's room in here. Now, obviously, this would all be on a computer. I actually was assigned a laptop that belonged to the company that I could use to fill out these forms. It was page after page after page after page after page on the computer. When it's printed out, it's a bit different. What you're looking for is a history of symptoms. Again, the triple Ds and the severity, frequency. So all that stuff. And the very first page there, after you find out why they're here, you're looking at a risk assessment. So risk or danger to self or others. Within this, you've got aggressiveness. Is it daily, weekly, monthly, past 30 or 90 days, past 3 to 12 months? Is it daily, weekly, monthly? Or not applicable? That's also a choice, or none is also a choice. Fire setting, homicidal, homicidal ideation, self-care risk, which means they can't take care of themselves, like basic hygiene, stuff like that. Self-injurious behavior, are you engaging in cutting yourself or doing other things to hurt yourself? Have you been a sexual trauma perpetrator or victim, suicide attempt or suicidal ideation? Yeah, that's a lot to unload. Hi, I just met you. You ever tried to commit suicide? Yeah. So next page, you've got symptoms and behavior. You're looking at anxiety, panic, again, with the same daily, weekly, monthly, last 30 to 90 days, last 3 to 12 months. Anxiety, panic, attachment problems, binging, purging with food, depressed mood, dissociative symptoms, impulsivity, lying or manipulative behavior, oppositional behavior, phobias, property destruction, running away, sexually inappropriate, social withdrawal, stealing, verbal aggression, decreased concentration, distractibility, hyperactivity, paranoia, poor judgment. Okay, you kind of get the picture here. Lots and lots of stuff. There's also right off the bat questions about alcohol use or abuse and other drug use or abuse. We go into it further on in the thing. Is there a history of abuse or neglect? Has it been reported? What was done if it was reported? Sexual abuse also. Current living situation. Who are you living with? Where are you living? Let's see. What's the atmosphere in the home? Is there a lot of conflict? Is it pretty calm? If you're dealing with children, you ask about the parenting that has been in place for those children. You ask about their financial situation, not because you're being nosy, but because, we have the possibility of hooking people up into social support. There are things that can be done if you need to get on food stamps, if you need some assistance with housing, if you need vouchers to get stuff from the food bank, or if you need monies to be able to get furniture that you desperately need, things like that. I did all kinds of things like that when I was working as a case manager to help people literally get furniture. I would get vouchers from different entities. There was a variety of things that we worked with. And, I get a couple $100. Now, it was not like I could go down to, Lasters or something and buy, $4,000 worth of furniture. It'd usually be, I get, $200 or $300, and we'd be able to go to a secondhand store and pick out, bare bones. Well, okay, there's a table, a couple of chairs, there's a crappy-ish, love seat. There's, a bed for a kid that needs a bed. I worked with people. It was amazing how many kids were sleeping on air mattresses. It doesn't take much to pick up a twin size bed, the secondhand twin size bed. And I always made sure there was a mattress, a zip cover on those too, because you really want to sleep on some other little kid's pee. Not so much. So things like that is why we ask about their financial situation, employment status. Do the parents have a job? Do you have a job if you're the person that's dealing that's come for treatment. Family spiritual issues and preferences, cultural issues or considerations for treatment, sexual orientation, gender or identity issues. These are all things that we would talk about right off the bat because they all have, a lot of impact on how you might approach someone, what kind of therapeutic methods you might use with that person. Community resources such as Open DCFS case. Are you getting food stamps, things like that? Do you have extended family that's supporting you? Do you have a tight church group that has resources for you? Things like that. Is there, public assistance that you're using for housing? A lot of things like that. One important question I always wanted to broach with my clients was leisure or recreational interest. What do you like to do when you're off from work? What kind of TV do you like to watch? What kind of movies are your favorite? Do you like to read? If so, what kind of stuff do you like to read? What do you do when you are off from work? Because that can tell me an awful lot about someone and how they think and how you look for entertainment. It does tell some things about you. And again, not trying to judge the person, trying to get a feel for who they are and what kind of things might speak to them. Sometimes you can get someone to talk about a fictional situation a lot easier than you can get someone to talk about their real situation. But you can use that filter of fiction to be able to deal with some stuff and get people to open up and start talking about something that might be hard to talk about. So that's something else that I would use. Legal assessment. Are you involved in the court system? Are you court ordered? Are you in the juvenile court system? Do you have a DCFS case opened on you because of child abuse or neglect? Were you the perpetrator? Are you the kid? Is there custody stuff that's going on right now with your parents and you as the kid, or are you having a custody battle with your ex? All those kinds of things having to do with the legal system are also really important pieces of information for us to know to possibly advocate for our clients. I wrote lots and lots and lots of court letters over the years because I had kids, well, obviously the kids that I had in foster care. I worked as a therapist for the alternative school here in Arkadelphia for a year, and I did write a couple of letters for those kids who had been involved in the court system and in juvie. So those are things that we also want to know. Educational information, again, if kids are in school, if you're dealing with a child, how are they doing? Are they getting along with their peers? Are they doing well in their work? Are they having real significant problems? Are they in normal classes? Are they in resource classes? Could we do something to improve their educational experience? Are they being bullied? Stuff like that. For adults, are you at the educational level that you want to be? Is there something we could do to help you get to that level? I helped people fill out forms, well, especially when I was a caseworker or case manager. I helped people fill out FAFSAs. I mean, you guys probably all know what that's like. It's a lot of stuff. I helped people fill out paperwork for applications for schools, for tech colleges, for Henderson even. I did all kinds of stuff like that. The kids that were in foster care I had several of the kiddos that I worked with that were in the long-term foster care that came to Henderson, at least for a while. And thankfully, I had several who went to Henderson but moved on to other things. One of them's a nurse now, and one of them owns a daycare center. So, I mean, some of these kids that went through some real bad situations when they were young, teenagers, still managed to get it together and, really do some good stuff. So those are part of the job potentially too. So we always ask about their educational information, vocational information for teenagers and up. What kind of job do you have? What kind of job do you want? And what can we do to get you from where you are to where you want to be? That's part of the counseling stuff too. Stressful events, family history. Is there, a history of family violence, abuse, neglect? Have you moved around a lot? I mean, that alone can be really tough and cause people to have a lot of social anxiety. Is there family substance abuse that's caused problems? Is there custody issues, divorce, remarriage, step families, all sorts of things like that? The biological side, we ask about developmental history. Were you born premature? Did you have to spend, the first month and a half of your life in a NICU or a neonatal intensive care unit? Um, were you full term? Did your mother use drugs while she was pregnant with you? Stuff like that, of course. Um, were you a sickly kid? Did it cause problems with your education because you were out of school a lot? So a lot of reasons. Um, medical history also, do you have any major allergies that affect you? And I'm not talking about like hay fever. I'm talking about like, yeah, I'm allergic to peanuts. Yeah, stuff like that can really interfere with people's, just kind of everyday functioning. Um, nutritional screening is part of it, especially for kids. When we're working with kids that were in really bad neglectful situations, I would go through the detailed version of that. Is there any past hospitalization surgeries for non-psychiatric issues? Trauma history, has there been head injury, fall injury, car accidents? Because head traumas can cause, a lot of additional issues, even aside from the obvious concussions and things like that. Sometimes it can cause some long-term other issues as well that'll manifest as psychological issues. Are there other medical things that we should be aware of? Are you sexually active? From what age? That can be a real interesting question. I was honestly kind of shocked several times when I, would ask these little girls who, one of the questions from gynecological history is like, when did you start your period? Just to make sure that things are normal. Oh yeah, I started my period when I was 10, they're 11, they're sexually active, and you're just like, oh dear. So that'll tell you a few things about a kid's situation. If you've got an 11-year-old that is sexually active, something's gone awry. That's not healthy. 11-year-olds are not ready for that. They might think they are, but they're not. And generally, when you're talking about 11-year-olds that are sexually active, they are not sexually active with 12-year-olds. They are sexually active with adults or people that are at least way damn too old for them. It is not okay if you're 17 to be having sex with a fourth grader. So yeah, stuff like that. Um, there's a pain assessment. Generally, that's more for adults, but I did occasionally have a kid that I would do this on. Psychiatric mental health history. Have you been on any medication for psychological issues? And what were they? So you have a list there that you could have. Treatment history. Have you been in inpatient care? Like, have you been in a psych hospital? Have you had prior outpatient history? Like, have you been in therapy before? And a really important question, did it help? Because sometimes that can give you a lot of information about a person. There are people who go to therapy because they want somebody to pat them on the head and go, oh, you poor baby, that must be so terrible for you. And as soon as you start getting real with them, as soon as you do any kind of even most mild confrontational thing about, well, okay, but have you thought about doing this? Or stop doing that dumb thing that's keeping your life a mess, they'll get pissed off and they'll quit. They will bounce as soon as you say something that they didn't want to hear. So that can also be something to just inform how you deal with a person, because if you know that they've been to 7 therapists in the last 2 years, they're probably somebody who's just not quite ready to do the work yet. Now, you might, be the person that can get through to them, but therapy is hard work. And I think for a lot of people, it might take a couple of stops and starts before they manage to actually, get to the point where they can do that hard work. I mean, you have to look at yourself and look at all the dirty things, dirty underbelly of stuff, and it can be very painful and difficult. But, generally the result is worth it, hopefully, anyway. Let's see. We've also got any kind of testing that you might have had done. If you're in foster care, if you've been in a group home, a shelter, boot camp, juvie, all those kinds of things. Is there a family history of psychiatric problems? Obviously, that's pretty meaningful. There's a substance abuse assessment, a page of just all these different substances that could have been abused. First usage, like how old were you When's the first time you did this stuff? When's the last time you did this stuff? I had kids that I worked with. It was like, oh yeah, I got high last week. Okay, moving on. And then frequency and quantity, like how often did you do it and how much did you do when you did it? So all things that you would want to know. Family history of substance abuse for mother, father, sibling, extended family, step parent, other household members. So, what kind of stuff was everybody in your house on meth except you? That's a pretty significant thing to know about someone. And then we have this mental status examination, which is basically just checking for abnormal appearance, behaviors. One of the things as far as appearance, are they appropriately dressed? Are they unkempt? Are they dressed appropriately for the weather? Like, it's hotter than the blazes of hell and damnation today. It's supposed to be 100 degrees today, right at. If somebody came into my office today wearing a parka, I'd be like, okay, what's up with that? Because it is way, 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 like 35 degrees too warm to be even wearing a jacket. So why in the world are you wearing a parka? Things like that might be a red flag. Cuts, sores, bruises, that could be an indication of drug use. That could be an indication of abuse if you're talking about children, or spousal abuse. There's all kinds of, domestic violence. There are all kinds of things. That being said, I also had a client that I was really kind of concerned about, and I am doing the intake, and because she had scratches all up and down her arms, and I was like, oh gosh, is this somebody that's a cutter, or somebody who does self-injurious behavior, non-suicidal self-injurious behavior. And as we were talking during the intake, I found out that she just has a bunch of birds, and they just scratch her up while she's messing with her birds. So it's like, well, okay, that's completely reasonable. And she's telling me about her birds and all this stuff. I'm like, okay, all right, that's totally okay. It's like, you might want to clean their freaking claws a little more often, but speech, is it normal? Is it rapid? Is it limited? Is it slurred? Is it too loud? Is it too soft? Those are all things that will give you more information about someone. Is their mood appropriate? Are they anxious? Are they having mood swings? Are they having, teary, like you can barely talk through their crying? Are they really irritable? Are they really apathetic? Those kinds of things. Are their thought processes relatively normal, or are they all over the place, loose associations, flight of ideas kind of stuff? Attention, concentration, are they able to follow your questions, or are they getting distracted halfway through? Are they having too many things in the environment that are getting their attention? Are they hyper vigilant? Are they scanning for danger like somebody with like really bad PTSD might do? So things like that could be part of it. If it's someone who's older, you could have memory testing in place just to make sure that you're not dealing with someone who has like a dementia type problem. There is a space here for estimated intelligence, and this is not to be judgy with people to go, oh, they're really not very smart, or they're, whatever. It's more to gauge like, okay, how am I going to deal with this person as a potential client of mine? Because if they're above average intelligence, you would work with them in some ways that you would not necessarily work with someone who is well below average intelligence. You would change your vocabulary, the sophistication level of your vocabulary. You would use, fewer big words, stuff like that. So you just have to adapt to that as a therapist. Does someone have insider judgment about their own behaviors and other people's behaviors? Do they have good insight? Is it impaired? Is it poor? All of that kind of stuff is part of how you would gauge the treatment for someone as well. So, those are all things that, we have. And when you do an intake interview, one of the first things that you do when you complete an intake is you come up with a tentative diagnosis. You come up with a general treatment plan for that individual. You're already planning on when you would discharge that person from services. So you're already thinking in terms of, okay, how long are they going to need to be in treatment? Now, of course, this is all adaptable. You do a treatment plan review every 3 months, but you're already planning for discharge as soon as you've done the intake. So that's something else that people may not be aware of. Okay, so there's that. All right, personality inventories. There are some different tests that can be done. Now, in my personal experience, I did not do a whole lot of testing. Well, I'm not, I don't have the credentials to do that, number one. But I did use a few kind of basic kind of worksheet things. There are a couple of inventories that I did use fairly often. There's the Beck Depression Inventory. You can Google it. It's all over the place. There's also the Manifest Anxiety Scale. These are two one-sheet, little short, basically quiz type things, and they are really good at giving you information about how anxious someone is from the Manifest Anxiety Scale, or what kind of depressive symptoms someone is showing if you suspect that they are experiencing depression. So those are two things that are very, very simple, very easy to use. Now, personality inventories like the MMPI-2, not so much with the easy to use. The MMPI-2 is a 567 question true-false test where you are looking for abnormal thought patterns. When you're talking about the MMPI, you're talking about finding out whether someone has fairly normal thinking. There are 10 subscales on it. There's one for psychopathic deviance. Yeah, that's kind of big. There's one for depression. There's one for schizophrenia. There's one for mania or hypomania. So there's a lot of different things that the MMPI is supposed to measure. There are vocational assessments that use the MMPI, like jobs that will ask you to take the MMPI. For some jobs, I am totally okay with that. Like if you're going to be doing a job where you are carrying a firearm, yeah, I'm totally okay with people making sure you are at least mentally stable. For air traffic controllers, people who, really their mental state is extremely important. There are some medical jobs that this would not be inappropriate. So those kinds of things. But boy, if you're going to work in accounting, I would not be okay with a company wanting to give you an MMPI when you're going to be working, a job that's you're just plugging numbers into a computer, and you're not the person handling the cash. You're not going to be easily able to embezzle money or something like that. There are a lot of places that use these kinds of tests kind of, I don't know, inappropriately in my book anyway. Projective personality test, you got the Rorschach and the thematic apperception test, otherwise known as the TAT. The Rorschach is the ink blot test that a lot of you have probably heard of or seen. It's really just a card with some ink blots on it. And you're asked to describe what you see. And through that's what they're called projective tests, but through your description of what you see, it's supposed to project your personality through that. I mean, I've never used it. I wouldn't ever use it. They're interesting, but I would not put a whole lot of clinical faith in those being particularly accurate. Thematic apperception test is where you've got basically these ambiguous pictures. They usually have people in them, where the subject's asked to tell as dramatic a story as they can about each person in these cartoon little drawing, and they're to make up this elaborate story. What's each individual person thinking? What's going on? What are they doing beforehand? What are they doing during? What are they doing after? And, like one of the pictures is a group of people sitting around a dining table, and a pretty normal answer would be, oh, they're getting ready for Thanksgiving dinner and blah, 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 blah. Okay, that's normal. They're sitting around trying to figure out which one of them is going to have to kill grandpa so they can get the insurance money. That's not so normal. So, there are ways that you can certainly project your personality through these things to seem either, more or less normal. But again, these projective personality tests are largely the realm of psychodynamic therapists who do the Freudian kind of stuff that's just not that common. You're not going to see these being used by people who use a lot more kind of cognitive behavioral stuff. So again, not going to see as much of that. Okay, so that's it for chapter 4. We'll start on chapter 5 on Wednesday. And that's that. Now, I just uploaded the last week's but they're audio only. I'm still trying to figure out how to get the video to work on it. But for right now, at least it's audio, and it is uploaded into the module part in Canvas. So if you're listening to this, check that out too. But otherwise, I will see you guys next time.